So BPH, we don't want to talk to the choir here about what the importance of this pathology is, especially in individuals. We have a obstruction, BPH, with symptoms, and the prostatitis in general are the most common areas that are being assessed by oncologists and even urologists in our practices, and also the correlation that they have with all the co-occurrences related to these issues. This is just to remind us the good relationship that they have, close relationship that we have between the prostate and all the different organs inside the pelvis that are going to condition or being affected by any kind of pathology that we find in the prostate. This is a donor person who was sentenced to death, donored his body, and we were able to do this. 50 microns slices in our frozen pelvis. So the pathophysiology is not well understood, but still we know that there are different factors that are going to be included into the development of this, in addition to the genetic factors. The usual patterns are mixed with predominant stromal hyperplasia. This is both the fibroconnective tissue and the smooth muscle that are going to be enlarged. There is really hyperplasia, the cells divide, is no hypertrophy. And then also the same path happens with the glandular components, and any kind of a mixture that there is going to be with prevalence of one of those cellular components are going to give probably some subclassifications of what BPH can be, either if it is mostly secretory cells, basal cells, mesenchymal or smooth muscle. This is just a cross-section of a typical BPH, in the predominant in the transitional zone. It is pushing the peripheral zone, this being one of the smaller areas in the prostate, in a normal prostate in younger individuals, grows at such a point that can also produce obstructions. In contrast, we can find some other individuals that have a very diffuse hyperplasia, as you can see here, that is universal, affecting basically all the glands around the urethra. And then under the microscope, we're going to find different arrays, architectures of the glands. They are all benign, but they can be very interesting in regards to the, for example, presence of cystic atrophy, that in this particular case, first they become hyperplastic and then they atrophy. Or the nodules are predominantly with fibromuscular components. We are going to have these fibromas, that they are different kinds of BPH with a predominant stromal component. And then finally, with the basal cell hyperplasia, in which these cells that are around the gland are going to be the ones that become hyperplastic, and then with the basically atrophy of the glandular components. This is an example of basal cell hyperplasia that is very difficult to identify when we have some questions in regards to confusing them with cancer. For example, usually the residents, it is the first thing that they find and said, what kind of cancer is this? And then finally we learn that this is just a hyperplasia of the basal cells. We did about 10 years ago, we started to we work 2 or 3 years with this MTOPS project. This is a prostate biopsy that has been stained with trichrome staining and with also pancytokeratin. So the pancytokeratin is staining the epithelial component, and the trichrome is staining the muscles red and the fibroconnective tissue in blue. So these are the 4 sections that we are going to identify. Basically using Photoshop, we were able to identify the different areas and do this special nice kind of a staining of the different sections. And then we are able to identify all or select the colors. And with that, using the same Photoshop, we can do a histogram in which each of the colors are going to be identified with pixels, and those pixels are counted in regards to the total. We can identify the percentages of each component, and then we were able to compare the individuals who were in the placebo branch arm of the project of the trial versus the individuals that were being treated. And then based on that, we were able, for example, to identify that there was a very strong association between the stromal epithelial and smooth muscle and luminal composition in regards to the presence in these nodules in BPH regarding the severity or benign behavior of prostatic hyperplasia. These nodules were very interestingly selected in the two groups. It's for showing a very significant difference in their proportion, and this was also the basis for the final project, in which the report was that definitely the combination of two different medications are basically more effective as compared with the placebos. So the reason or the way that we were able to find these differences was just using this kind of a old-fashioned AI, and then but it was done just by hands, and the interpretation was in a very primitive way with some kind of a statistical analysis. Now, moving into the acute and chronic prostatitis, is one of the most common pathologies in individuals that are younger, and especially they are representing more or less 25% of all outpatient urology consults, and they affect every single individual, about 5% between the 20 to 50 years of age. However, regardless of this knowledge that we have and the symptoms, et cetera, in general, it's been described that there is a misdiagnosis, misclassification, and there's poor management, and this is also a concern in managed care and patient care because there is overall patient dissatisfaction. So we need to always consider the presence of these infections, especially in individuals when they have this kind of any kind of condition that may generate chronic UTIs, for example, that can go and ascending and going into the prostatic tissue. And the same pathology or the epidemiology that we see in urinary tract infection is going to be found in this kind of prostatitis. And also remember any kind of medical manipulation that is going to produce the presence of these microorganisms in the prostate. And also remember that the prostate biopsy is contraindicated in the presence of any kind of acute inflammatory process. And this is something that I want to stress out. This is why biopsy of a prostate in an individual had an increased PSA, and it was reported because we had to do second opinions and then come with this material that we need to diagnose and compare it with the outside report. And this was reported no evidence of malignancy. But this is not clinical pathology correlation. We need to have, this patient will have a very high PSA, as you can imagine, and then you have pus inside the glands, and then all these are going to condition the increase in the PSA. And if there's no good communication between the clinician and the pathologist, we are going to, the only thing that we are going to find is just an increased PSA, and it's probably logical to make a biopsy. The presence of these inflammatory processes is extremely important to consider, and the reporting of BPH and acute inflammation is an important element in the pathology report, and you need to always, as I mentioned before, have this good relationship with your pathologist. Then the benign prostatic hyperplasia, that is basically one of the common problems, can be associated, and then one of the recommendations is that that was done in 2002, that the benign prostatic tissues, they should be just reported benign prostatic tissue, and we don't agree with that because we can use some words instead of making diagnosis of BPH. At least we can say that there is moderate or severe stromal fibrosis and or inflammation, and what kinds of inflammation. And remember that the size of the prostate is a very important element. And if you are going to have a biopsy in a prostate that is normal size versus a biopsy in a prostate that is enlarged, we are losing the access to anterior or apical tumors. And then we have also in our practice that the fact that we find no evidence of cancer doesn't mean that there is no cancer, because approximately 30% of patients may have cancer with negative biopsies or no clinical significant cancer. And the presence of acute inflammation also may be confusing element, that the fact that the prostate biopsy is negative doesn't mean that the patient doesn't have cancer. And also, just to remind you many other pathologies: atrophy, corpora amylacia, calcified, and different degrees of calcifications, fibromas, different types of fibromas. And if you find fibromas, be careful, because many times they are diagnosed and it's a fibrosarcoma that looks like a benign tumor, but the patient has a malignancy. And so you need to ask the pathologist to do further studies. This is in seminal vesicle calcifications. These are nodules of granulomas with giant cells in patients that had urothelial carcinoma, and we were treating with BCG, and then usually we are going to find these granulomas. And this is interesting. I find a lot of these thrombi in the major arteries in the prostate. The individuals that have been diagnosed with prostate cancer, they get a prostatectomy, and in very significant, more than 50%, I find this thrombosis. I don't think that they are produced or induced for therapy. These are older patients, and I'm concerned about what kind of effect this may have. And finally, this kind of very interesting lesion, probably you are not familiar with, but this is what you do when you do a prostate biopsy. And these are the areas of necrosis that are produced. And also, remember that when you send biopsies, they need to be treated very carefully. Patients, the biopsies are very thin, and they, especially in a climate like Denver. I have a colleague that just came from the south, and she was putting her biopsies in a kind of a gauze before she put them in formalin, and they were just crazy. You can see this drying artifact, and she was surprised when I told her that she has to put the biopsies right away into the vial, otherwise we will have these problems. So these are the references. Here is David in 2010 in our institution. Thank you so much.